So,
Mm, mm. Okay, go ahead.
uh, I would like to check for the other body, the rashes, the body rashes, the lymph nodes, the mucous membrane, the eyes, and the
What
lymph
you
nodes.
want to look for?
Look for any lymph. Hypertrophic LP,
Okay, exactly. Okay.
squamous cell carcinoma, then what else? If kids, I would think about varicose stage or IP. Or portal excessive portofilin or iatrogenital cautery or iatrogenital surgery.
Okay.
Uh,
blistering or including the pemphigus diseases, and it can be due to paraneoplastic pemphigus or other drug causes. So other group of the differential diagnosis were including infections such as the bullous impetigo's, and then also we need to rule out if patient having edema, then it can be due to edema blisters or any due to underlying diabetes, diverticulum bullosa.
But what would point away from edema, blister, or bullae diabeticorum?
Sorry.
What is the main feature that the patient has that would point away from bullae diabeticorum or edema blister?
If bullae diabeticulum, usually the base is over the outlying skin is normal. There is the absence of the necrosis or erythema. So another causes to be considered would be drug causes such as fistula eruption with hyperpigmentation and with the blistering changes. And also we need to also not to miss out any erythema multiforme, which is complicated with blister as well.
Good. This patient actually has bullous FDE, so you are on point. So what are the features that you will look for in the patient that will support your diagnosis of bullous FDE? Where else would you examine?
For bullous FDE, otherwise we also need to check those areas such as the periorificius, periorus, and also the palms and so.
In one of our MCQ, how do you differentiate between bullous FDE generalized versus SJS?
FDEs versus SJS. Okay. In SJS,
generalized bullous FDE,
generalized bullous FDE. In the SJS, usually more mucosa will be involved. There will be at least 2 mucosa involvements.
Good.
And of course, also for the lesion wise itself, the bullous FDE usually predisposely over the distal limbs, perianal started areas, and SJS will be usually generalized and also over the trunks and limbs as well. Other features, FDE, maybe the base. One is more to pigmentation, another is more to the targeted lesions.
Okay. And generally, the bullous FDE is relatively well compared to SJS. Tell me, what are the common drugs that can give rise to FDE in adult?
In adult, the common causes of FDE will be things like even the NSAIDs and the paracetamol, and also
paracetamol for kids, kan? Salah, kan?
Yeah.
Adult tak kan? PCM for kids, kan?
Okay.
Sebenarnya itu Dr. Dom mention, kan?
Okay.
Correct me if I'm wrong. Lagi?
And NSAIDs and also antibiotics such as Dosi, it's not mistaken, Dosi and Bactrins.
I rasa yes. I think cyclin group juga. Alright. Do you know besides drug, anything else that can give rise to FDE?
Other than drugs, FDE, not sure.
Food coloring. Which color?
Food coloring, the
blue,
the dye,
red, pink, black. It's yellow.
Yellow, okay.
Okay, very good.
Yellow.
Okay, so I don't have anything more to add. Sama apa you sebut, alright. Okay, next one would be Priya. Are you there?
Yeah, I'm here.
Okay. Come, this one is actually at the back, and then this one muka lah.
Muka, okay. Okay, so on examination of this patient's face, there is an ill-defined erythematous patch over the right side of her nose, involving the tip of the nose. There's some overlying blisters as well noted on the nose, and there is involvement of the medial canthus of the eyelid. On inspection of her back, there is multiple erythematous patches with ill-defined borders over the back.
All right. Okay.
Okay.
I would advise maybe use the word grouped vesicles.
Group vesicles. Okay.
Okay. So what would be your provisional diagnosis?
Okay, so my provisional diagnosis would be disseminated herpes simplex infection. And then I would also like to offer a diagnosis
Disseminated
of
herpes simplex ke herpes zoster?
because ada dekat back then a differential of disseminated herpes zoster as well.
How would you differentiate between uh, chicken pox, okay, versus sorry, oh tu chicken pox, sorry, salah. Okay, teruskan, lepas tu.
Okay, and then also I would think of bullous impetigo.
Alright, okay.
Okay, and then blistering lesions. What else? Can I mention like your autoimmune blistering disease like bullous pemphigoid?
I think it's worth mentioning. So the
Okay.
base is inflamed and there are tense blister. Although it doesn't look like it, but I think it's worth mentioning. Lower down in the, I would say lower down in the list, I would think of autoimmune. However, it's unlikely because of blah blah blah. Okay. So tell me, how would you, besides doing, let's say this is a case of herpes zoster, a disseminated
Mhm.
herpes zoster. Do you know how many types of herpes zoster presentation? One is disseminated that you've mentioned.
Right, and then
Apa lagi?
you have your your localized herpes zoster,
Good. Lagi?
and then localized disseminated
There are two more.
two more. Mm, not sure.
Herpes zoster duplex and herpes zoster multiplex.
Okay.
Okay. How do you differentiate between how do you differentiate between disseminated herpes zoster versus varicella zoster?
Um, so for herpes zoster, the initial lesion, you will see that it doesn't cross the midline. And
Good.
then you will have it extending towards the periphery and disseminated, whereas with herpes simplex, you would see that in the initial part where the blisters
Not
start,
herpes simplex, varicella zoster.
varicella zoster. Okay, and then you have your polymorphic
Good.
lesions. So you get lesions at multiple different phases. So you have ulcers, papules, pustules, and then some healing and some fresh.
Okay. Can you tell me the phases from the start to the end? Which one starts first and ends with what?
For your
Varicella zoster.
for varicella zoster. So you have your varicella zoster.
They normally start with what?
Normally start with your prodromal phase.
No, bukan. The lesion. Tadi kan you mentioned there are several phases, right? So do they start straight away with ulcer?
No, so they start with like a papule or sometimes it can be a blister.
Mm-hmm.
And then after that, it becomes ulcerated.
Mm-hmm.
And then it can become crusted.
Okay, and necrosis. So how do you treat this patient?
So for her,
this is a case of disseminated herpes zoster.
Disseminated herpes zoster. So I would give her IV acyclovir,
Mm-hmm.
15 mg per kg for 1 week, 3 times a day. So about 500 3 times a day for 1 week.
And how long can you extend? How long can you extend the acyclovir? Does it have to be fixed at 1 week?
No, so you can extend it to about another 10 to 14 days. So depending on the clinical resolution. So as long as there's no new eruptions and you see mostly 80% of the lesions are healed with crusting.
Okay, good. All right. Okay, so I just put a bit more inside bite and possible systemic contact dermatitis. Okay, this is a pregnant patient. Siapa Sekejap. Wahida? Wahida ada ke?
Yeah.
Come on Wahida, ni pregnant patient.
Pregnant patient. So ni kaki, tangan, badan. So on clinical examination, there is multiple hyperpigmented papules over the extensor part and lateral of the right lower limb, extensor of the upper limb, and also at the back of the trunk. On the overlying surface, there's also mild scales on the background, and some appeared excoriated as well. So I would like to examine kalau boleh the anterior tongue to see if there's any associated blister accompanied with this distribution of the lesion. So my differential would be number 1. Hello?
Yes.
I would put polymorphic eruption. Tadi kau cakap pregnant lah. Or should I just assume orang ni tak pregnant? Number 1, I would put the polymorphic eruption of pregnancy. It can also be atopic eruption of pregnancy. Kalaulah I also need to consider apa nama ni Lincoln planus.
Okay, good.
Tapi of course you'll be able to see scales tu lebih kepada Wickham striae. What else? If let's say nampak depan badan dia, you would consider things like pemphigoid gestationis lah. It can also be drug eruption, macam lichenoid drug eruption as well.
Okay, I'll stop you there. So, going back to your differentials, of all the differentials that you've mentioned, which one you think is most likely? Considering these are also the lesions that you will see on the front.
I think yang paling would fit the provisional diagnosis would be atopic eruption of pregnancy, because they look edematous from the picture shown.
Which type of atopic eruption?
Would be edematous. Tapi some look nodularis go. Yang dekat anterior lateral thigh ni looks a bit macam tebal kan. It can be I would put edematous, or it can be prurigo like.
I think I would this one we
edematous.
This one papular type, the P type.
Oh, the P.
What are the differences besides the lesions? What are the typical distribution for the papular type in contrast to the eczematous type?
Normally, if let's say papular type, betul. The papular type is more of a trunk ending limbs. And then kalau eczema dia dekat over your face, your neck, and the popliteal area macam your eczema patient.
Alright, so tell me what are the 5 pregnancy dermatosis? So you've mentioned atopic.
Tadi polymorphic eruption of pregnancy.
Lagi?
And then ada pemphigoid gestationis.
Good.
And then you have your intrahepatic cholestasis of pregnancy lah.
Okay, there should be one more kan?
Tahu 4. Is there any more? Ingat 4? Intrahepatic,
There should be one more kan? Bukan ke pustular eruption? Pustular eruption psoriasis pun termasuk ke?
Oh, ni okay. Yes.
Kan?
Betul.
Which one has a negative effect to the fetus? Which one are not?
Yang negative effect to the fetus would be your pemphigoid gestationis. You have a higher risk of having premature delivery or low birth weight. Ataupun neonatal tu sendiri can have pemphigoid gestationis as well because they can be transferred. Rasanya yang I think Intrahepatic cholestasis also can cause preterm birth and stillbirth.
Yeah, so itu lagi bahaya lah. So how do if
Uh,
when do you suspect a patient to have intrahepatic cholestasis of pregnancy?
Selalunya diorang your second and
jawab in
third
English,
trimester.
Jawab in English.
Usually it'll be usually it'll be at your late second and third trimester.
Okay.
Lepas tu apa soalan tu balik? Come again?
What other clinical features do they have?
Clinical features.
Mm-mm.
So normally they have pruritus dekat pruritus over the extensor limb, abdomen, their back, and also it's worse at night. And then you'll be able to see there's abnormal in the liver transminases enzymes.
Okay, before we go to investigation, what do you see in the patient besides the what do you see in the patient? You mentioned pruritus is actually the symptoms. So clinically, what are the signs that you look for?
There will be no cutaneous signs.
They are
Except for you'll be able to see macam excoriation. You'll be able to see linear excoriation.
yes, you won't.
Linear excoriation and macam ada erosion with scabs.
Okay, besides derm punya signs, any other signs that you look for?
Jaundice.
Yes, jaundice. So how do you treat intrahepatic cholestasis of pregnancy?
We give them the ursodeoxy cholic acid dengan cholestyramine.
Okay, and what is the best way to resolve the lesion? The lesion, the disease.
What's the best way to resolve the lesion? Tak tahu.
Delivery.
Oh, delivery. Okay.
Okay. Okay, just one last question. You've mentioned just now for pemphigoid gestationis, the risk of transfer to the baby, kan? Does this risk last for?
Apa dia? Come again? What?
How long does the risk of the autoantibody being transferred to the baby? So how long does the risk of the baby getting bullous pemphigoid themselves?
Oh, no. Is it 6 months? I'm not sure.
3 months.
Berapa?
3 months.
3 months. Okay.
Go back and check lah.
Okay.
Alright. Okay, next. Case 7. Jason, are you there, Jason?
Hi, Awin. Yeah, I'm here.
Okay.
So, if I may start, this is an image of the anterior abdomen of this individual. So, what I can see are multiple annular to polycyclic erythematous, I would say, thin plaques,
Yes.
central clearing. So it's distributed basically predominant is grouped basically grouped predominantly from over the lower abdomen and ascending in a circular circumferential manner up to mid abdomen as well, with somewhat sparing of the umbilical region. If I may say, I do see some very slight limited scaling
Yes.
over the edges of the margin of this thin plaques.
Okay, good.
Okay. Would there be any other images or just purely the
Yes.
lesions are this side?
This here.
The lesions are this side. So I would go along the approach as a papillosquamous form of rash. Papillosquamous for this region here. Based on the size, maybe I would offer a provisional diagnosis of perhaps a very unusual form of guttate psoriasis, maybe a lichen planus. Annular. Okay, fine. So we go for annular, small, atypical, perhaps a tinea corporis.
Good. Okay.
We go for tinea corporis. When you go for lichen planus, not so popular, central clear. Maybe those generalized granuloma annulare.
Good. Okay.
What else?
Which type of granuloma annulare?
The usually the generalized granular annulare, which is seen commonly in those with diabetes and the immunocompromised.
Okay.
A very unusual presentation, perhaps maybe because of the central clearing and the multiple sites. May I offer maybe a tuberculoid leprosy per se, Hansen's disease,
Okay.
atypical sarcoid presentation. If it's an elderly individual, also perhaps an erythema annullary centrifugum, but usually those are much more larger and more concentric, I would say.
What kind of scale do you expect to find in EAC?
EAC, you usually see a trailing scale.
Scale.
Yeah.
So how many types of EAC do you know?
I unfortunately don't have that answer. I'll find out.
I
Sorry.
think superficial and deep.
Okay.
Again, I lagi lama lupa, tinggal pada you all, so correct me if I'm wrong, but better check up.
Okay.
And what are the, okay, EAC is usually lah the one that I've seen in my practice. They are not usually a primary diagnosis on its own. They are typically secondary to something. So what are the secondary causes of EAC that you know of?
Secondary causes of EAC, if I read from the literature, can be due to infection, could be due to solid organ tumors, can be due to lymphomas. So you need to do an extensive workup to identify the source of that particular rash. So maybe examination of the lymph nodes, peripheral blood films, examination for any organomegaly, and maybe perhaps a screening CT scan, TAP, to look for any. Yep.
So if I tell you that this patient, when you examine the face, you can see that there are greasy scales overlying erythematous patches on the seborrheic area.
Yes.
What would you be thinking of as an overall diagnosis for the abdomen?
Greasy scale. So if you're giving me, okay, seborrheic dermatitis on the face, on the abdomen.
I tell you, okay, let's say the unifying diagnosis is seborrheic dermatitis. Any particular type of seborrheic dermatitis that can look like this?
Okay. I don't have that answer. I'm sorry.
It's petaloid type.
Okay. Okay.
Okay, that's good. You are on point. Memang diagnosis dia tinea corporis. This one masih tengok I remember Prof Zira ke Prof Ada cakap, oh soalan cantiknya, ingatkan something interesting. Tengok straight tinea corporis je.
Okay.
Okay.
Can.
So the last case lah, I prepared 20 tapi I rasa kita buat last. Maybe if we have time, we do it some other time. Alright. Oh, sorry. Okay. This one, Fadilah ada tak? Fadilah tak ada Ding, are you there? Ding pun tak ada ke? Firdaus ada tak?
Ada.
Jom, last one.
So on examination of this lady, there are multiple hypopigmented plaques
Okay.
over the extensor upper limbs, bilateral breast, lower abdomen, and the extensor part of the lower limbs. In between the hypopigmentation, there are there's one blister on the right forearm.
Okay.
And then there are a few areas of hemorrhagic crust on the upper limbs, breast, and lower limbs. There are also surrounding areas of hypopigmentation, probably a PIH.
Okay.
So I would like to. There's also one area of erosion on the right lateral side of the right breast superficial erosion.
Yes.
Okay, so I would like to examine the oral mucosa, the eyes, and the genitals to see the extent of the involvement. So at the moment, my provisional diagnosis, I'm thinking of autoimmune blistering disease.
Good.
Probably bullous pemphigoid because it's dealing with scar, which means it's something subepidermal.
Okay.
So my differential would be epidermolysis bullosa acquisita,
Okay.
maybe linear IgA bullous disease, uh, yeah, and other blistering disease such as paraneoplastic pemphigus,
Okay.
and depending on the involvement.
All right. So what else that the patient has in this patient? Apa cakap ni? What else does the patient has that points towards subepidermal blister besides having a tense blister and a scar? Anything else that you see?
Uh, because the crust are hemorrhagic, so
Good.
it means it involve at least the dermal vessels.
Good.
I'm trying to look for milia.
Good. There's no milia, but good.
Okay.
Satu lagi.
Satu lagi apa?
You've mentioned about the pigmentation. You want to describe more about the pigmentation?
Oh, is it because certain areas of the hypopigmentation there is like perifollicular.
Good.
Differentiate.
Okay. How do you differentiate between bullous pemphigoid and EBA?
There are multiple subtypes of EBA, but one subtype is similar to BP.
Okay.
So,
What test can you do?
so for clinically, for the test, salt split skin lah would be the thing that can differentiate BP and EBA. So in the salt split skin,
How do you do the SST test?
yeah,
Tak apa, yang tu hafal dia orang suka tanya.
Yeah.
So what do you expect to find in salt split test?
I remember it put the biopsy, I think, in the 1 mole of normal cell line or something, and then it will be separated at the lamina lucida. So then the fluorescence will deposit on the roof in BP and on the floor in EBA.
One molar of normal cell line. Kena ingat berapa lama tau dia rendam tu.
Okay.
And then berapa lama lepas tu pula dia berapa lama dia rendam dan untuk dia baca lepas tu.
Okay.
Okay. What are the treatments that can be given to this patient?
So for moderate to severe bullous pemphigoid, we start with systemic steroid lah, prednisolone, 0.5 to 0.75 mg per kg depending on the response, and then topicals, especially for mild bullous pemphigoid, super potent topical steroid, and then steroid sparing agents, including doxycycline, azathioprine, maybe methotrexate.
Alright. So besides doxycycline, any other cycline antibiotic you can give?
Tetracycline.
Tetracycline usually must be given with what?
The vitamin niacinamide. Niacin.
Betul. So any biologics that can be given for bullous pemphigoid?
Rituximab and Dupixent.
Dupixent, yes.
Dupilumab.
Satu lagi?
Satu lagi.
Not in the guideline but has been in studies. Satu lagi? Salah satu juga yang selalu jumpa dalam derm punya ubat. Tak ada lah psoriasis dia penyakit lain. Untuk penyakit gatal-gatal juga.
Biji gatal juga.
Omalizumab.
Omalizumab.
Not in the guideline lah, tapi has been several reports of its use. Okay.
I think I saw in the S2K guideline. They mention omalizumab.
Alright, so I rasa kita stop dulu Nanti ada masa I bagi tahu kat Umu, kita buat another day pula.
Okay.
Okay.
So,
Bye.
Thank you.
Thank you,
Thank you, Amin.
Amin.
Thanks so much.
Thank you.
Thank you.